Uh, Hi, everyone. Welcome to this webinar entitled Not Just the Virus, Using HIA to Address the Wider Health Impact of COVID-19, Three-Country Perspectives. My name is Thierno Diallo. I'm an assistant professor in the Faculty of Nursing at the Université Laval in Quebec City in Canada. And I'm also co-chair of the International Union for Health Promotion and Education Global Working Group on Health Impact Assessment, or HIA. This webinar was organized by the Global Working Group on HIA as part of the celebration of the 70th IUHPE anniversary. I would like to thank the IUHPE co-organizer of this webinar, Stefan van der Broek, the IUHPE Vice President for Scientific Affairs, Sione Tuitai, the IUHPE Vice President for Communications, and Madeleine Malone, Project Lead for Non-Communicable Disease Prevention and Advocacy at IUHPE. I would like to thank Madeleine for all her support. The Global Working Group on HIA is one of the 7 working groups of the IUHPE. The mission of this group is to support the development of HIA as an approach, practice, and process. The group's objectives include to enable discussion, debate, and share learning among researchers, practitioners, policymakers, and communities engaged in health and other forms of impact assessment in order to develop a research practice policy agenda for advancing HIA. We currently have 16 members from different parts of the world, and we also have a Francophone subgroups that aim at enabling practitioners and researchers from Francophone countries to exchange on HIA. And before we begin, just a few technical informations. Please, if you are facing any technical issues, please let us know through the chat box. Madeleine is here with us today to assist us with technical needs. Thanks a lot, Madeleine. And the webinar is planned for 1 hour.
Oh, sorry, Thierno, you're muted.
If you have any questions, or if you have any other general messages or statement, or if you want to share any resources, please use the chat box to do so. I hope that we will be getting a lot of questions and comments from the audience. And finally, please note that this webinar will be recorded and posted on the IUHPE YouTube channel for later viewing, in case of you don't have time to follow the webinar right now. And today we are pleased to have 3 great speakers with us. Mrs. Liz Green, Dr. Margaret Douglas, and Associate Professor Fiona Haigh. I would like to thank Fiona a lot for her contribution to make this webinar possible. Thanks a lot, Fiona. And I know that it's very early in the morning in Sydney.
I've had my coffee. I'm ready to go.
Okay. Liz is a consultant in public health for policy and international health, and the program director for HIA at the WHO World Health Organization Collaborating Center on Investment for Health and Wellbeing. And she has a very good experience in HIA. Margaret is currently co-director of the Masters of Public Health program in Edinburgh University. And Fiona is director of the Health Equity Research Development Unit, a joint initiative between the University of New South Wales Centre for Primary Healthcare and Equity and the Sydney Local Health District. She is also the co-chair of the IUHPE Global Working Group of Health Impact Assessment, and I think she is also a member of SOPHIA, the Society for Practitioners in Health Impact Assessment. Thanks so much, all for being with us today. And thanks so much again, Madeleine, for helping us. And our webinar will compare and contrast 3 international COVID-19 focuses on HIA from Wales, Scotland, and Australia. And we will draw on this experience to consider how HIA can support a health in all policies approach and improve the impact of policy response for health and equity. I think that's enough for me, because we just have 1 hour. I don't want to spend all the time, just making that statement. And at this stage, I'm going to hand over to Liz, and who is going to be our first speaker, our first presenter. And Liz is going to give us also an overview of what is HIA, Health Impact Assessment. Liz, over to you. Thank you.
Thank you, Thierno. So I'm just going to set the scene for the 3 of us, because the HIAs are about comparing the types of approaches we took, and more than about the findings really of the HIAs. So for those of you who are unfamiliar with health impact assessment, then this is the ultimate definition. It's called the Gothenburg Consensus. And in a nutshell, health impact assessment looks at a policy, a plan, or a project, and asks, will it have an impact on health and well-being? And generally we mean by that wider WHO definition of health, so physical, social, mental well-being. If so, who will it have an impact on in the population? So which groups are maybe more vulnerable to any health impacts from that policy or plan or project? How will it impact the population? So how will those impacts manifest themselves? And that's generally through the wider determinants of health. And they can be both positive or be opportunities to maximize health and well-being, or they could be negative or unintended negative impacts, which could be detrimental to health and well-being and those groups who might be affected. And then we sort of stand back and say, okay, we've got all this evidence, because HIA is evidence-based, which can be quantitative or qualitative or mixed methods, and sort of assess it, triangulate it, analyze it, and say, okay, so what does this mean? What is that picture of impact look like? What are the positives? What are the negatives? And what could be done about it? Are there any practical recommendations we can make to address that, to sort of strengthen a policy or mitigate for any impacts? HIA process, I won't go into all of this, but it's generally routinely a 5-step process, which flows like this. Yeah. So generally HIA is a 5-step process, and it's routinely described as linear, as shown in flowcharts as a very linear process, but actually it's quite iterative. And you go through screening, scoping, the appraisal, which I just talked about, make those recommendations, and then generally a short report is produced, which can be used to inform and influence decision makers or support the actual HIA dissemination. And then we've got monitoring and evaluation, which is something that, or we term it review and reflection as well in Wales, because it very much involves reviewing and reflecting on the actual process that we undertook, and what were the benefits, what did we learn? Next slide, please, Fiona. So the aim of this webinar is not really to talk about the actual findings, but I think it would be remiss of us not to actually highlight this. So the population groups that were affected were both direct and indirectly through transmission of the virus and infection, and then mortality and morbidity, but also indirectly through those wider determinants of health, which I referred to. So this is just a slide that kind of compares and contrasts actually the direct mortality impacts. So we know that COVID, for example, has had high levels of morbidity and mortality, or death and illness, on older people, those from minority ethnic groups, those with pre-existing conditions, including obesity, diabetes, respiratory conditions, and also those who live in deprived areas or areas of deprivation. And so we've got, on the one hand, those direct impacts, but on the other hand, we've got those indirect impacts. So our 3 HIAs look at lockdown, look at the implications of staying at home, physical distancing measures. And whilst it was a protective measure for everybody in the population in lots of ways by controlling the transmission, it negatively affected a wide range of groups. And you can see that there are some different groups in those indirect groups, such as children and young people, young adults, those on low incomes, because being required to stay at home, homework, had a massive impact on people's ability to earn money, or they had to pay extra for food and fuel while they were at home. So those kind of impacts as well. Fiona, if you want to come out of that now, yeah, there's the path. Oh, I was going to say the pathways of impact were the wider determinants, and so those were mental well-being, living conditions, transport, travel, the disruption to essential services such as education, disruption to healthcare services and the provisions around lots of services moved to online or were ceased, and also things like social isolation and familial relationships were big pathways, and we saw increases in reported incidents of domestic abuse and violence against women, for example. So there's some of those pathways, those wider determinants through which this all manifested itself. So I'm now going to hand over to Margaret. She can talk about the Scottish example, and then we'll go back to mine, and hopefully the slides will work. Margaret.
Thank you very much, Liz. Okay, I'm quite nervous now. I shall try and share my slides. I hope this will work. Okay, good. That looks like they're working. Okay. So I'm Margaret Douglas, and I'm going to talk about a very rapid health impact assessment that we did right at the beginning of the pandemic. And we were trying to assess the likely impacts of the measures that would be needed to prevent transmission of COVID-19 in Scotland. And I'd like to acknowledge my colleagues listed on this slide who were all co-authors on this health impact assessment. Okay, so how this health impact assessment came about, effectively this is our screening process really. So if you cast your mind back to early to the middle of March 2020, it was very clear that we were in a pandemic situation. There was growing anxiety and uncertainty about what was going to happen. People working in public health were desperately trying to respond to the cases, and were completely swamped with the acute COVID response, and nobody really knew what measures were going to be needed, but it was very clear that there were going to have to be significant restrictions on people's movements and a very, very likely lockdown. So that was the context in which we did our health impact assessment. The Faculty of Public Health is the professional body for public health specialists throughout the UK. And in Scotland, we have an advocacy group that is part of the Faculty of Public Health in Scotland that leads on public health advocacy for us. And at this time, in the middle of March, a few of us who were involved in the advocacy group met by teleconference to discuss our concerns about some of the likely wider impacts of the restrictions that we knew were going to have to be brought in. The main area of concern was the impact of economic disruption, and in particular, the impact on people who were in low-income groups, who were in insecure employment, who would have to stay at home, would be unable to work and would lose income. But in the discussion, it was clear there would be a lot of other wider impacts of the social distancing measures. And so we agreed to do a more systematic health impact assessment, a very rapid one, to try and understand what those might be and try and feed that into decision making to influence some mitigation measures. So this was our health impact assessment process. The health impact assessment took place over less than 1 week, between the 13th and the 20th of March 2020. So this was before the UK went into lockdown on the 23rd of March. And because at that time the guidance was continually changing, and the first thing we had to do was to articulate our assumptions about the social distancing measures that were going to be needed and would be put in place. Normally, when we do a health impact assessment, at the scoping stage of trying to identify the relevant populations and impacts to assess, we bring together a group of stakeholders, and we sit around a table, or these days around a screen on Teams or on Zoom, and we use a checklist to systematically go through and identify relevant populations and potential impacts on health determinants. And it's in that discussion between stakeholders that you really have the value, and it really does help to clarify what are the most important impacts to be assessed in the health impact assessment. In this situation, we were not able to do that. We just didn't have the time or the ability to do that. So what we did instead was I circulated our usual checklist to colleagues who had been at that teleconference and asked them to go through it themselves systematically and send and reply to me with what they thought were the relevant populations and impacts. And I also went through the checklist very systematically and picked out what the relevant populations and impacts were. And we then shared our ideas by email. And towards the end of the week, we had discovered Zoom, and the authors of the health impact assessment were able to discuss and refine them a little bit more. But in the meantime, we had used the initial set of impacts that we generated to develop research questions of the things that we needed to know to assess these impacts. And we then collated available systematic reviews to look at how likely those impacts were to happen, and routine data from Scotland where available or UK-wide where not available, to try and give an estimate of the number of people who were likely to be affected by each impact. And we put all of that information together in an impacts matrix. We drew up a causal pathway showing the different pathways between the social distancing measures and impacts on health. And we generated quite high level recommendations for each of those impacts to try and mitigate the negative impacts that we had identified. By the end of the week, we had pulled all of that together and we put it into a paper that we submitted to the British Medical Journal, which was subsequently published. And they produced this very nice infographic that you can see on the slide, which summarises the pathways between the social distancing measures at the top and the impact on health outcomes at the bottom. So this was an extremely rapid piece of work, and we were all having to fit this around our other work. This was not anybody's day job. We all had other work that we had to do during the day as we were also trying to work on this health impact assessment. We also produced a longer report that had a little bit more detail than the BMJ paper. So how did we use this health impact assessment? We had done this effectively as an advocacy health impact assessment. No decision maker had commissioned us to do this, but because we were public health specialists and most of us were working in Scotland and some of us were actually employed by the organisations that then became Public Health Scotland, we were able to feed it directly into decision making. So the very next week, on the 25th of March, we held the first meeting of what became the Social Mitigation Cell, which was part of the COVID-19 response in Public Health Scotland. And at that meeting, we used the health impact assessment as a framework to identify the relevant areas of impact. We then set up subgroups to look at those areas in more depth, and I've listed the subgroups that we had on this slide. And each subgroup was asked to involve and work with a wider group of relevant stakeholders to build on the impacts matrix that we already had, and then to use that information to review the mitigation measures that were starting to be put in place and inform future mitigation. And all of that work later developed into what became the COVID-19 Social and System Recovery Work Programme within Public Health Scotland, which I can say a little bit more about later on, but I think I'm probably spent more than my 5 minutes. So I will now stop sharing and pass back to Liz.
Yeah, thank you, Margaret, except Fiona's going to share my slides so that we don't have any problems again. Seeing as we seem to have them with my laptop. So please. I'm going to...
Please go ahead, Liz.
Yeah. So I'm going to talk about the health impact assessment that we carried out in Wales. Like Margaret, I've got 3 slides. And basically we carried out a health impact assessment during the first lockdown, and we carried it out in real time to inform and influence decisions as they were being taken. I'm Programme Director for Health Impact Assessment of Public Health Wales, which is the National Public Health Institute. And we have a dedicated HIA unit, which is the Wales Health Impact Assessment Support Unit. But because we're a National Public Health Institute, we were also, like Margaret said, working on the actual COVID response at the time. And we very much, as the advice agency and the public health agency for Wales, we're in quite a good position to carry out the HIA because we have the tools and the knowledge and the resources. And actually we felt, or it was felt, that we had it was the best use of our skills to try and better understand what these wider health impacts or wider harms may be, because everybody was purely focused on the morbidity and the mortality. And as a public health agency, HIA is the best tool to sort of advocate for health in all policies and health and well-being and equity. So we felt it was a great way of leading by example. And Wales has a Public Health Act where HIA is statutory in specific circumstances, or will be. So actually it was great for us to sort of showcase the actual work that could be done and inform and influence as we were going along. So this HIA was carried out in 8 weeks, really, under the first lockdown. Can I have the next slide, please, Fiona? Thank you. So where Margaret's was rapid, and I mean really rapid, a week is amazing, and ours was 8 weeks, which 8 weeks was just still pretty rapid. The HIA in Wales was more comprehensive, so it followed all the stages of the process that I've showed you, but also it used evidence that was a literature review, grey literature review. We looked through peer-reviewed papers. We gathered all the health intelligence statistics that were being published on a daily basis, but also that we knew about, for example, you know, the index of multiple deprivation in Wales, or different population groups, and all those different kind of demographic data, as much as anything else. But we also interviewed key stakeholders, and there were about 15 interviews. So we mapped, we did a stakeholder analysis. Who were the groups that were going to be particularly affected as part of our screening? And as part of the scoping, we identified, well, who should we talk to? And instead of it really being internal, we decided to focus on external stakeholders in the main, but actually it sort of morphed into people that heard about the HIA and they said, can we contribute? Can we talk to you? So actually we ended up carrying out more interviews than we actually anticipated. But it made it very participatory, it made it very rich, and it actually gave us a lot of insight into what was happening on the ground that hadn't been published yet. So that was one of the real sort of values of this process, really. And it was transparent. So HIA, one of the principles is transparency and openness and ethical use of evidence. So we published all the evidence online as part of our reporting, and all 3 reports, exec summary, the main findings report, and the supplementary information that has all the evidence in it, they are all published online on our website. So next slide, please, Fiona. So in terms of its impact and its influence and the way it's been used, it's actually been quite an interesting process to follow through. So it was presented to actually the Welsh Government ministers, including the Health Minister and the chief executives and the chairs of the health boards in at the end of June, start of July of 2020. So just as it had been published and finished, it was being presented by the director of our directorate, and it actually made people think. So it came back, the feedback came that they said, wow, we've all been so focused on this awful awful virus and the deaths and the illness and the hospital services and the healthcare services and what we do in lockdowns, that we haven't really thought through some of these wider harms. And so to have this work has been very, very useful. It was also presented to a wide range of international networks to sort of share our learning as well. And again, people were like, well, this is really great. You know, can we use it in our own context? And you'll see there, actually, one of the bullet points is that it's been replicated. So by publishing everything, including our process and all the evidence, what we gathered, it's helped other agencies to replicate it in their own context as well. And also it's been used as a basis for Welsh Government further work, and Public Health Wales's work plans, and informed some streams. So one of the things that I thought about when I was writing the report and we were constructing and analysing it is that actually for the UK, the pandemic had also come on top of things like Brexit and also climate change. There was huge amounts of flooding in Wales in early 2020, and they all kind of came together in a cumulative way for some communities. So it wasn't just about COVID, but it was exacerbating other possible negative impacts of these other big events. So it's led to other streams of work as well, ran the Triple Challenge, but also home and agile working, mental well-being, the impact of the pandemic on children and young people, and their mental well-being is just being finalised and will be published in the next couple of months. And like Margaret, we published a journal paper as well, so that people could sort of better understand what we did and what the findings were and some of the results. So, and it's also appeared in the Chief Medical Officer's report in 2021 as an example of some of the wider work looking at the COVID pandemic and its impact. So I can talk about this some more, but I'm going to hand back to Fiona now. Thank you.
Okay, I will just get my one up and going.
Thank you very much, Margaret and Liz. Thanks a lot, Margaret. That's a very good display on how to use HIA in an emergency context. Very interesting. Some people, think that HIAs are long and burdensome, but this is a good example of very rapid HIAs, 7 days.
It is. I always say health impact assessment is as long as a piece of string. It can be a very quick process, or it can be a very, very long process, and you have to fit it to the context and what it is you're trying to influence.
Yeah, which fits nicely with my one, which is the longer process, perhaps more burdensome. We'll see.
Over to you, Fiona.
Thank you. Yeah, kia ora, everyone. Before I get started, I'd just like to acknowledge the traditional owners of all the lands that we're on today. So I'm up in the Blue Mountains west of Sydney on Darug and Gundagara land. I'd like to acknowledge elders, past and present, and also acknowledge any Indigenous colleagues we've got with us today. But the health impact assessment I'm talking about didn't actually happen where I am today. It's based down in Sydney in the Great Eora Nation with the Gadigal, Wongal and Bedegal clans. So this HIA is one that was done as part of an HIA within a local health district. So as Thierno mentioned earlier, I'm part of a unit called the Health Equity Research Development Unit, which is a partnership between a university and a local health district in Sydney. And so Sydney Local Health District is a very urban area. It provides health services to approximately sort of 700,000 people, but it also has about 1 million people who come into the district every single day to kind of work and study, and is responsible for 6 hospitals, including one that's a virtual hospital. And so early on in the pandemic, we were, as we kind of worked closely with the health district, we were already sort of finding opportunities to try and engage with them around thinking about the health equity impacts of the pandemic. And we were doing little short pieces of work. So for example, when they were planning activities, we were doing quick evidence reviews, or what we call equity checks, which are almost like little mini desktop HIAs that you do in 1 or 2 days. But we realized that there was an opportunity and a need to think more sort of systematically and comprehensively about the equity impacts of the pandemic, particularly around thinking about those longer term impacts. So thinking about what it's going to be like on the other side, which we're maybe getting towards now. And so that was the setting for this piece of work. And so it was, I guess you could say it is quite a comprehensive health impact assessment. We've been working on it for a good year now, actually, partly because of the way we've carried out the process, but also, as with a lot of us, we've also been working in the COVID response as we've been doing the HIA. So in terms of some of the key milestones, I think in terms of our process, at the start, we knew it was really important to get high level support for this piece of work. We wanted to actually influence planning and decision making. And so we got the support of the chief executive of the local health district. And we also presented our plan to carry out an HIA to the board of the health district and got their support and buy-in. And so that really set us up with a good governance process framework for carrying out the equity-focused health impact assessment. We have a really big steering committee that's got a mix of internal stakeholders, but also a lot of external stakeholders from local sort of NGOs and also community-based groups. And for the scoping process for this equity-focused HIA, we almost did a mini HIA in itself. We already did an initial literature review. We did 23 what we called scoping interviews, so really conversations with key stakeholders, internal and external, to understand what they saw as the key sort of emerging areas of potential areas of focus. And so we ended up working with the steering committee to identify 3 main areas that we looked at. So one of them was actually COVID itself, so in terms of infection and transmission and the equity related impacts of that. And then our other 2 key areas were thinking about how changes to work have affected health equity, so things such as working from home and sort of lockdowns. And then the other main area was changes to health services. And we had some particular focus populations as well around health workers, culturally and linguistically diverse communities, older and younger people and women. And as I mentioned before, our focus is really thinking more about those medium to long-term impacts and developing recommendations that are focused particularly around recovery, but also thinking about what we can learn for the next pandemic, but also more generally, similar to how Liz was saying about how this is influenced by other things such as Brexit and climate change. We're also sort of thinking that this is informing thinking and planning for future challenges. Australia, that's probably more bushfires. So at the moment, so we've finished off all the evidence collection. So we carried out a whole range of focus groups and interviews, again with internal and external stakeholders. We've done 5 literature reviews as part of this, and then we've also continued doing these brief sort of evidence checks and equity checks, and those have been informing decision making as we go along, but also informing our health impact assessment. So the stage we're at now is we're just finalising writing it all up, and we're beginning to do some consultation and validation around it. So we're going to be sending it out to everyone who's been involved in it, also getting it peer reviewed, and then we'll be presenting it to our board, and probably there'll be a whole lot of activities after that. So I think key things in our process were really that we've tried to engage constantly throughout with key stakeholders, and it's been a very iterative process in terms of we've been constantly feeding information into decision-making processes, but also learning from that for the health impact assessment. And this is just an example of early on. Our chief executive actually sent out a letter to all the staff in the district. So that's 16,000 people, basically saying, telling them about the project, but also inviting them to get in contact with us. And a little bit similar to how Liz was saying, we'd done our stakeholder mapping. So we'd identified, different people in areas that we wanted to talk to people in. But then we also ended up engaging with lots of people who sort of got in contact with us and wanted to tell us things or just learn more about the process. So in terms of impact and influence, we haven't quite finished, so we probably can't talk about such clear outcomes as Margaret and Liz. As I said, we're in that validation process at the moment. But we've already had quite a lot of influence through the process. And it's been this really, mutually reinforcing iterative process, I think. So being part of the system, like being based within the health district, meant that we've constantly been able to kind of identify opportunities to feed information into decision-making processes. And we have this sort of role within the district in some ways. We're part of it, but we're still an academic unit. And we can act almost like a critical friend sometimes in terms of providing advice. We've continued to do those equity checks and evidence reviews that have often been targeted at particular decision-making processes, so plans that they've been developing. And also through those interviews and focus groups, we've been constantly engaging with people. And that's often led to little sort of follow-on things and conversations around, an example would be there's a lot of planning at the moment about how do you prioritise and restart services and thinking about how do you integrate equity into that process. I think we've kind of supported some equity champions along the way and maybe found a few new ones to develop and encourage. And we've also had some opportunities around capacity building and engaging different people within the process. And another key sort of activity that we had is we have something called Equity Fest each year, which is meant to be sort of a celebration of equity-focused activity. And this year we focused on COVID, and we had 3 sessions with a couple of hundred people each time, where we really unpacked what's been happening in terms of what happened, what have we learned, what do we need to do. And again, that sort of has ended up in that sort of, it was informed by the work that we were doing, but has also informed the findings of the FIA. And so we feel like we've been planting lots of equity seeds or sparks or fires, hopefully, within the district. So I'll just stop there. Okay, back to you, Thierno, to lead our discussion.
Thank you very much, Fiona. This is also a very interesting example on how to integrate or to consider equity in HIA. And we had 3 very good examples on how to use HIA in a health emergency context. That's very, very interesting. And I'm gonna see if we get some questions in the chat. Let's see. I think I have not. I think I have seen one question. Yeah, it's about how you communicate to the populations and how to involve participatory process. But how you communicate the result, I guess, to the population and how to get a kind of participative HIA. I'm going to start with Liz first, and then I will pass the floor to Margaret, and I will end up with Fiona. Liz, over to you.
Right, okay. So in terms of communicating it, we've used quite a wide range of different platforms. So because most of them had to be virtual or digital, social media, Twitter, LinkedIn, all those kind of platforms, we utilised and mobilised those. We had a number of webinars, both internally in Wales and externally, but also as people heard about the HIA, and not just this one, but the Home and Agile Working Health Impact Assessment or the Housing HIA, people were coming to us and saying, we've heard about this, can you come and talk at our groups? And so then we were talking to our stakeholders who were then asking, could they be participants in the other HIAs? So it was really, really useful, and it kind of snowballed in a way like that. So in terms of the communication, but also the engagement of getting people on board for other pieces of work, that actually worked really, really well.
Thanks, Liz. Over to you, Margaret.
Thank you very much. Well, as you'll have seen, for our initial health impact assessment, we didn't have any engagement of any stakeholders at all. It was done in a tearing hurry just by a few public health folk. But in the follow-up work that I spoke about, so the social mitigation work, we did engage with stakeholders, and all of those working groups involved different stakeholders in different ways, but they all had stakeholder involvement. And that was absolutely critical, I think, to understand, what mitigations were being put in place, how successful they were, and what else was needed. And also, importantly, disproportionately what was possible in the different contexts. Some of those groups still exist, that might have changed their name, or they might have become something slightly different, but a lot of those groups have still continue. And as an example, I chair a group that's about transport and the impacts. Initially, it was about the impacts of the pandemic on transport and what that meant for health. And we've now agreed that it's been such a valuable experience and such a valuable forum for bringing together transport professionals, voluntary organisations, a few public health folk and others, that we've decided to continue that group and use that as a way of looking at wider transport policy. So we've been able to, the initial health impact assessment sort of kick-started that, but because it's been so useful to work together in that way, we've agreed to continue doing that. And through that group, we've carried out a further health impact assessment of road space reallocation, which was one of the major mitigation measures that was attempting to give people more space to physically distance. We're doing other health impact assessment type work on wider transport policy. So it's very much a health and all policies approach, working in partnership to understand the transport sector and what that means for health. And there are other similar groups which have continued and have sometimes taken slightly different approaches, but it has kick-started quite a lot of other work with stakeholders and others in Scotland.
Thank you very much, Margaret. We are getting a lot of questions in the chat box. Over to you, Fiona.
Yeah, okay, just quickly, I don't have much different really to say than Liz and Margaret, except for that we focused a lot on engaging with stakeholders throughout the process in a lot of kind of ways that are maybe, we had our sort of formal, interviews, workshops, but also constantly engaging with sort of existing groups to have that kind of engaging with people who are actually going to implement our recommendations. I mean, we did find it challenging having to move everything online, and I think that's one of the things that we recognise in our report. We did engage with community members, but not to the extent that we would have really hoped, because it's really hard doing this stuff online, with people, and also when people have got a lot going on in their lives. And so that meant that we did have some workshops with community members. We also had workshops with existing groups within the system. They always have these groups associated with hospitals, consumer groups, client groups. But we also then had to draw on people who were engaged with different community groups. So having to take that sort of step back. I think we've ended up doing really sort of comprehensive participation engagement. And the other key element, though, is what we're doing now, which is actually going back to them and making sure that they're part of actually that developing recommendations and validating that process, so that we haven't just kind of taken the information from people and then we've developed our own kind of thoughts about it, and that's the end of the engagement.
Thank you very much, Fiona. Andy is asking us to ask a question in person. Please, Andy, go ahead, turn on your microphone and maybe your camera. So please go ahead. Thank you.
Hello, and apologies. Even though I write for a living, I'm a dyslexic and I get a bit wary with the written word at times. So I've just started looking at international COVID recovery policies, a project for WHO Europe. It's going to be very quick and dirty, unfortunately. And they have these absolutely massive policies, which include things like Next Generation EU, which is dedicated funding of 800 million euros for 6 years, which are dedicated to powering the recovery from COVID. And what I'm learning is that they're using COVID, I think appropriately in lots of ways, as a springboard to move to, I suppose you could describe them as next generation policies, although they've been around for a while, if that makes sense. So things like digitizing the economy, the green revolution, so on and so forth. Lots of very large policies with lots of funding, lots of enthusiasm from policymakers and from the public. Lots of positive impacts potentially, although some potential negative impacts in inequalities, which I will get to. Sorry, I'll try and be quick. Nebulous things, but major changes in our societies, which are going to have profound impacts going forward. I'll give one example of a potential negative. So, we know that the impacts of COVID have been disproportionately impacted on women. Women as informal carers in particular. So when the schools closed, it was women that were responsible for care. When the charities and community voluntary services couldn't visit to help you with care of relatives, etc., they suffered. Local authority care stopped, etc. So women have suffered particularly badly. But the policies that I've seen so far in the recoveries are focused in sectors that are male dominated. So the digital economy and the kind of engineering that's involved in these new green technologies, electrification of cars, etc. So there's definitely an imbalance. So sorry, it's a bit of a big question at the moment. I'm wondering what you think about this situation and whether you in your units have plans to look at these big shifts that are potentially going to occur in our economies and our society as a result. Sorry, I got to the question eventually.
Yeah.
Okay, thank you, Andy. Fiona, you want to answer first?
Yeah, I think for our equity-focused HIA, that's definitely actually one of the core areas of focus, is that we're particularly looking at what happens next. And in terms of thinking about how, like, the utility of HIA, the timing has to be right, and the timing is quite good at the moment in terms of potentially influencing those policies. I mean, we're thinking, I guess we're smaller scale than for example, Liz and Margaret are looking at more country level. We're looking at a local health district. But at the moment, there is those kind of like fundamental changes and thinking going on, and we're well placed to kind of insert our findings into that. And I think the findings from all of our HIAs as well, although they were COVID specific, they're actually more generic in terms of application, because a lot of it, we've seen with COVID that the equity aspect of it is the key. That's the major impacts, and it's really brought it to light, and there's a lot more kind of public consciousness about it at the moment. So so I think we've got a good opportunity to think about those bigger sort of policies that are not just COVID specific.
Thank you, Fiona. Margaret, I don't know if you want to comment on that.
Yes, I mean, I agree with Andy. I think it's really important that we engage with this at whatever level that we can. And I think it's important to look quite holistically at how these proposals affect different groups of people and affect health. I think the challenge is that it's not really enough just to swoop in and do a health impact assessment. You need to build relationships and work on an ongoing basis. I'm kind of struggling with how to do that at an EU level. I'm hoping Andy will be better placed to do that than I might be. But I think we really do need to take this wider health and all policies approach, where we work with partners, and health impact assessment is a really important part of that. But it doesn't mean just swooping in, doing a piece of work and going away. You need to sort of keep building the relationships on an ongoing basis, and that also gives you the opportunity to get in earlier. If you can see what's coming up, you can then get in at an earlier stage in policy making when you're more able to influence. So I don't know how to do that at a wide Europe-wide level at all, but I think wherever we are, we're positioned to work with whatever context we're in, and I think we all have to do that at every level, because all of these things have effects at all levels.
Thank you very much. Moving now to Liz.
I think you've highlighted some really relevant and interesting things there, Andy. You talked about, have we got any plans to do any future work around these big events? And I think one thing that's shown for the unit in Wales is that actually we can tackle these large scale events. I know it's not an EU level, but at a national level. So Brexit is a national health impact assessment that we carried out. Climate change, we're just finalising a major HIA on that, COVID as well. But also it's highlighted the need to do further work. So in answer to your question about women, the answer is yes. And Laura Evans, who's in the WIAZU team, my colleague, is online today, and we've actually been talking about this yesterday. So we're just finalising a short briefing paper on the impact of COVID on women, particularly in relation to their employment. and also the sort of unconscious biases that were pre-existing and maybe have been exacerbated by the pandemic. And what does that mean, and how could it be addressed going forward as part of the recovery? We've also looked at things like, I mean, this was only published not last week, the week before. And this is around spatial planning, because there's a window of opportunity, and I think that's one of the things that I think we would probably agree, that as public health, we've got a window of opportunity to use the pandemic and these moves to different ways of working and looking at different issues to try and integrate health and wellbeing into them, whilst others are looking at that now or soon will be as part of that recovery.
Thank you very much. I'm watching the time. I'm sorry. I don't think that we're going to have enough time to answer all the questions, but just one question and maybe a short answer. How are you financing the HIA? Did you have sponsoring?
I think we've all done it within our existing work, haven't we? You know, it's part of our kind of mandate really to do this kind of work. But I think we've all actually had to fit it around other, you know, like we've all, when we've talked about this previously, you know, for all of us in our teams, it's been quite a big job.
Yeah. I mean, I tell the story of, I got up one morning at like 4 o'clock in the morning so that I could break the back literally of the wider determinants of health section of the stay at home HIA report before I ended up working on the COVID pandemic response at 10 a.m. because that was my window to do that, and weekends and outside those parameters, which is very much Margaret and Fiona's experience. So maybe we've made it sound easier than it actually was.
Yeah, and I think it really signals how important it is to actually have capacity kind of within systems to do this kind of work, because it is often really difficult to get it, you know, funded externally. So I think it, you know, for all of us, we managed to kind of do it as part of our roles. Yeah.
So I have one more question, short answer. What issues and challenges did you face in conducting the HIA? Quickly, short answer, because I think this is a very important question, you know.
I don't think there's a short answer to that. I think there are many different challenges. I think we've kind of alluded to a lot of the challenges already. The fact that the public health community was and still is swamped with other work, but it's so important that we make time to consider social determinants of health and to work with partners. And this is one of the really important ways that we can do that. So I think it is making sure that we make space to address these wider issues as well as the immediate COVID response. And that is an ongoing challenge, I'm sure, for all of us. There are many others. I could list a whole lot of challenges, but perhaps that's the most important one.
Thank you very much. I don't think that we're going to have, again, time to answering the other questions. I would like to thank very much all the panelists, and this has been a great opportunity. Thank you very much to all participants for spending this time with us. I know it's a very interesting topic, but you will be able to find a lot of documents online, report, article, etc. And also just let us know, I just want to let you know that we are organizing a sub-plenary session on HIA and health in all policies during the IUHPE conference in May. Hopefully we'll be able to attend this event, and look forward to see you again and to keep pushing through and see how we can really make HIA a useful tool for planning the post-COVID-19 recovery. That's very important. You know, we were talking about the COVID-19 response, but now we have to think about the post-COVID-19 recovery phase, and I'm sure that HIA is a useful tool. And so thank you again, everyone. And Yeah, we just have 1 minute. Have a good day, a good afternoon, and a good evening, depending on where you are on the earth, because I know that some people are in Australia, in Europe, in Canada. And again, I'm sorry we were not able to answer all the questions, but they were very, very relevant. And I'm happy that the topic.
Yeah, and please feel free to contact us. I think all of us are happy to be contacted if anyone wants to follow up around particular questions.
Yeah, thank you very much, Fiona. Yeah, do not hesitate to contact the panelists if you want to get more information, or if you want maybe to have an answer of your questions. Yeah, it will be a pleasure for them to answer. Merci beaucoup. Et thanks a lot again to Liane for helping us organizing this webinar. Merci beaucoup, Liane. Thanks you again.
Thank you, everyone.
Thank you very much.
Yeah. Bye-bye.
Thank you.
Bye-bye.
Bye.